Hi, my name is Julienne Cranch. I completed my practicum through the Canadian Public Health Service and was placed with the Northern Health Region, also known as the Northern Regional Health Authority, or I'll be referring to it as the NRHA, in Thompson, Manitoba. My practicum work involved evaluation of interventions taken related to a syphilis outbreak, and today I'll present on an evaluation proposal of enhanced prenatal syphilis screening policy. So the NRHA is one of 5 regional health authorities in the province of Manitoba, and it's the largest geographic health authority, covering 62% of the province, but is only home to 5.8% of the provincial population. There are 3 main sites within the region: Thompson, The Pas, and Flin Flon. I was placed in Thompson, where the arrow is pointing. And outside of those areas, there's many small outlying communities. So syphilis. This was a promotion that they put together a few years ago. So the identified health concern of syphilis is a bacterial infection passed through all forms of sexual contact and can also be passed from a pregnant woman to her developing fetus, which is known as congenital syphilis. Symptoms of syphilis may be nonspecific and not very noticeable for individuals who are infected, leading to delays in diagnosis and testing. But once syphilis is diagnosed, it is considered a reportable infection in both Manitoba and in Canada, which means that new cases are reported for surveillance data. And within Manitoba, the regional health authorities are responsible for following up with clients who have positive syphilis results to ensure that appropriate treatment has been received, and also to provide contact follow-up to help decrease and prevent further spread of the infection. Over the past decade in Canada, rates of syphilis have been on the rise, with a 101% increase in national rates from 2003 to 2012. Syphilis has also been on the rise in Manitoba since 2009, and a provincial outbreak was declared in 2015. So specifically within the NRHA, from September 2014 to December 2015, there are 31 cases of syphilis diagnosed, with 71% of cases reporting heterosexual relationships only, and 35% of cases in women of childbearing age. When syphilis is in the heterosexual population, there is a risk for congenital syphilis. And in 2015, the NRHA had the first case of congenital syphilis diagnosed in the province in over 20 years. Congenital syphilis can result in serious complications for an infant, including enlarged liver, spleen, bone deformities, loss of hearing, or in up to 40% of cases can result in spontaneous abortion, stillbirth, or death of the newborn. As pregnancy progresses, the risk to the developing fetus increases, but congenital syphilis can be prevented. Treatment of the mom with penicillin is 98% effective in preventing congenital syphilis, which shows the importance of early detection and treatment of maternal cases. So standard recommendations were in place in Manitoba for women to be routinely screened for syphilis in the first prenatal visit, which is generally within the first trimester of pregnancy. And now, because of the advanced surveillance data available to show the specific characteristics of the outbreak in the NRHA, this led the medical officer of health for the region to implement enhanced prenatal syphilis screening policies in 2016 to align with Manitoba Health and the Public Health Agency of Canada for areas experiencing heterosexual syphilis outbreaks, which means that all women residing in the NRHA, regardless of individual risk factor, will have rescreening done for syphilis at 28 to 32 weeks of gestation, which is the beginning of the 3rd trimester, or also considered as mid-gestation, and again at delivery, in addition to the routine 1st trimester screening. With this change in policy, it is important to establish if it has been implemented correctly and if it's doing what was intended by facilitating early detection of prenatal syphilis and prevention of congenital syphilis. So there's multiple components that go into an evaluation proposal, from a literature review to a logic model, identifying evaluation questions, establishing data sources, and identifying measurable indicators. And central to all of this is engagement and collaboration with stakeholders. So we'll take a bit of a closer look at some of these components that I worked on. So I looked at the literature to address our enhanced prenatal syphilis screening, or 3rd trimester rescreening recommendations, and effective intervention in identifying maternal syphilis and preventing congenital syphilis. Findings from the literature included an evaluation of enhanced prenatal syphilis screening policy in the context of a heterosexual outbreak in Alberta. Over a 2-year period with a sample size of just under 100,000, PLIT AL found that just 20.7% of women had all 3 recommended tests done on time. But from that, 98.5% of women had at least one syphilis screening test done during pregnancy. But specifically, due to low uptake of the mid-gestation syphilis test and limited value in identifying new cases, it was discontinued 2 years after it was implemented. Further findings of enhanced prenatal syphilis screening policies in different geographic regions in the US, where there are high rates of heterosexual transmission of syphilis, compliance rates varied, but consistently the first trimester test was higher than the rescreening test in the third trimester. So from the literature available and identifying what needs to be known from this policy given the heterosexual syphilis outbreak is still occurring in the NRHA, the following evaluation questions were established. So have pregnant women in the NRHA received enhanced prenatal syphilis screening tests as recommended? And are the enhanced prenatal syphilis screening recommendations of value in identifying syphilis and treating it in the prenatal period? Or in other words, are the maternal cases being detected and treated within an adequate time frame to minimize transmission and the impact to the fetus? So learning about the kinds of data sources available and what they can and can't show us is an important consideration for evaluations. So here's a data flow diagram that shows one of our main data sources. So Chatham Provincial Laboratory in Manitoba is the only lab that performs syphilis testing in the province. And they're also the only lab that performs routine newborn metabolic screening tests, which are collected on all newborns in the province at delivery. By identifying all newborn metabolic screening tests done on residents of the NRHA within an identified time period through CADAM's databases, the newborn's unique identifiers can then be linked to their birth mom's unique identifiers, and then we can retrospectively look at her syphilis testing history during pregnancy and at what stage in gestation this was done in. So this is just a portion of the framework to show how the evaluation questions are linked to indicators, the data source, and how they'll be looked at, basically to find the proportions of pregnant women fully receiving, partially receiving, or not receiving the policy. For example, in the first indicator on the slide, the number of pregnant women having all three recommended syphilis screening tests at the recommended times, and comparing that to the full pregnancy cohort. Different subgroups for analysis have also been suggested, and it will be important for the final stakeholder group to identify what would be of interest and also what would provide the most utility for practice. For example, the second indicator on the slide, looking at the number of women receiving syphilis testing at delivery and looking at this per delivery site. So this is important because the NRHA is the only regional health authority that has implemented the enhanced syphilis screening policy. But some women within the region, if they have higher risk pregnancies, they may be flown down to Winnipeg to deliver, which is in a different health region. Care providers there might not be as familiar with the recommendations that are in place if they don't see this population as often, which makes the delivery testing not necessarily correlated to the previous prenatal testing done. So just overall, evaluations of public health interventions are imperative to ensure that practices are up to date and effective in the context of the community and the public health delivery system. So some key take-home implications for public health practice include collaboration. So the importance of collaboration within policy change and evaluations to learn from multiple perspectives, whether that's among public health professionals, between public health and other healthcare providers, or between public health and the community. Also, it's vital to know the population you are working with and what the impacts to health are and what the barriers to receiving these are. And even the importance of knowing the organization population that you're situated within, the connections there, and then also the resources available and what is truly feasible within that organization. And finally, knowledge translation, the importance of knowledge translation in interpreting surveillance data and how that can impact policy, and also communicating policy change with the appropriate frontline users. And finally, how results can be clearly communicated to influence practice. So I just wanted to take a moment to say thank you to my supervisors, Dr. Michael Isaac and Lorraine Larocque with the NRHA, and then also Tammy Stewart-Chester with Public Health Agency of Canada. And then to my first and second readers, Nigel and Nate, for all your suggestions for my report. Thank you so much. And that's the beautiful scenery that I had in northern Manitoba while I was there.
Thank you, Julienne. Questions? Oh, and Lynn has one.
Good presentation, thank you. So, to the best of your knowledge, did the health authority ever give any consideration to testing the partners of pregnant women at the same time frames?
Oh, at the same time frames? That's a great question, Lynn. As far as to my knowledge, I don't know about that. The recommendations that are in place, like the communicable disease follow-up for the province of Manitoba, if a case were to be determined is plausible, they do contact tracing. So at that stage, but that definitely could create some delay, right? But that's a really great suggestion that the partners could be tested at the same time as the pregnant mom. That's awesome.
Other questions? Oh, yay.
Thanks. My question is just in relation to the rationale of testing them on 3 different occasions. I guess my question specifically is there evidence that a significant number of women were tested negative and then followed by positive results at delivery?
Yeah, so that's the possibility. Within, when there's a heterosexual outbreak, that's the possibility that the first trimester testing either happened too early to the exposure and the syphilis is still incubating, or like it hasn't seroconverted yet, there hasn't been enough antibodies that have been produced yet, or potentially the mom's becoming infected after that first test. So that's the rationale behind it. With the first and the second test, there's still the opportunity to provide adequate treatment to prevent any of this complications of congenital syphilis, whereas the delivery screening is more so just kind of determining if it might be a case. But yeah, basically the rationale is just to provide more opportunities for testing in the context of a heterosexual outbreak, because there have been information out there that healthcare providers might see a woman and just consider her low risk or not do a full sexual health history, and that assumption in a heterosexual outbreak is not good. We just need more opportunities to test and then treat.
Nigel has one. Actually, I'll sneak a question in while I'm walking this over
Yeah.
to Nigel, and it's about the Know Your Population part of your implications slide.
Yes.
So tell us a little bit about the populations in northern
population, yes.
Manitoba and
Yes.
how that impacts how this service will
Yeah.
be delivered. Yes.
So particularly in the north, there's the small and rural communities. And we know from a community health assessment, it's a few years old now, that within the north, rates of inadequate prenatal care are actually 3 times higher than the rest of the province. So we know that the accessibility is not necessarily there, and a lot of the times the women have to come into those 3 main sites, Thompson, Flin Flon, or the PAW, for their first prenatal visit, again for their ultrasounds, and then prior to delivery. So if they're not coming, or if a healthcare provider is not coming to them, when are they going to access this testing, right? So that was another rationale that kind of draws back to your question a little bit as to why these enhanced recommendations were implemented, in that it just gives even more opportunity for the healthcare provider if the woman is right there to offer these testing, just so there's not as many missed opportunities. Also within the north of northern Manitoba, 70% of the population does identify as Indigenous. So that's another one. And we do know through Public Health Agency of Canada that there are disproportionate rates of bacterial sexually transmitted infections in the Aboriginal population because of historic discrimination and systematic discrimination. So that's another consideration.
Great talk, and this is not an ethics question. First question is why you spoke of an increase,
Yes.
and I just wondered, is there any explanation for that, and what sort of projections are there? And the other thing is, are there issues around comorbidity?
Oh, comorbidity. I didn't look at comorbidity too much. In regards to the rates, do you mean Canada-wide or specifically
Well,
Manitoba?
actually, even Canada-wide and
Yeah.
again in Manitoba.
Yeah, so Canada-wide, we do know that over the last decade, that rates have increased dramatically. Typically, throughout most of Canada, rates or individuals infected with syphilis, over 90% are actually males, and from the population of MSN, populations of men who have sex with men. Whereas in northern Manitoba, we're seeing more of a heterosexual outbreak, which is interesting. And I just read an article not too long ago from Winnipeg, and so they were seeing within their outbreak, first MSM outbreak, but then they were seeing more cases of heterosexual So they were suspecting in that it's not necessarily a transition in the trend, but more so an expansion of the outbreak. Within the NRHA, I haven't had any direct or any kind of strong evidence as to why it's in the heterosexual population, but it just seems to be that case. This article that I cited from Alberta, during their outbreak that started in 2007, they noticed similar trends that within the north it was a heterosexual outbreak, but within the south it was a MSM outbreak. Mm-hmm. So it was quite interesting.
Thank you.
All right, I'm scanning the room for any final questions. There's one more.
Oh.
I'm just wondering if there is any interest in doing an environmental scan and engaging other provinces, because BC, for instance, has a lot of data on this and at the BC CDC, so that could inform some of the strategies that you might be implementing or upstream strategies for that.
Yeah, definitely. And there has been enhanced surveillance data available once or prior to even the province implementing it. Tammy, who's the public health officer for the region, she implemented an enhanced surveillance gathering tool, so asking questions about where individuals were meeting their partner, where they were having sex, those kind of things. And then the province implemented an enhanced surveillance form to use throughout the province. So from that, there was surveillance data as to where individuals are meeting, and within the north, many of the cases are meeting at house parties or through families and friends, those kind of connections. So yeah, it's quite interesting, and that's a great suggestion for an environmental scan as well, to see what's going on in other provinces. Thanks.
All right, thank you. I think we'll let you off the hook. You've answered lots of questions, so thank you, Julienne.